today for the third and final part of what has been an important and amazing series of conversations on type 1 screening, monitoring, and treatment. Even 5 years ago, we weren't talking about early stage type 1. For many families, type 1 presented itself in dangerous situations such as DKA or very close to it. So, with that in mind, we're honored to be convening experts today in this space to share important knowledge on early stage type 1. Part 1 of our series in July was on screening. Part 2 in September focused on monitoring. And today we will focus on how these previous steps are very important for understanding what clinical trials might be suitable for you or your loved one and what treatment options there might be. Together, we'll explore how this science is shifting our approach from reactive to proactive care. I was diagnosed in 1983, and I'm inspired to know how far we have come. And actually, just yesterday, there was some news about a possible faster track FDA review for teplizumab, even when one is already in stage 3. We will discuss more if we can. So for today, one major theme comes to mind, and that is why is keeping beta cell function at the core of the current treatment and trial happenings? Basically, insulin is not the same as insulin. It matters where it comes from, within your body or outside of your body, such as exogenous or injected. So let me now thank our sponsors. diaTribe cannot do this without our sponsors supporting diaTribe, where we bring you information such as today. We truly thank Sanofi at the platinum level, Xeris at the gold level, Abbott, Lilly, Sequel MedTech, and Vertex at the silver level, and Dexcom at the bronze level. I will now turn this over to Dr. Diana Isaacs from Cleveland Clinic and Dr. Natalie Bellini from University Hospitals in Cleveland as our moderators. We are so fortunate to have you both, two truly passionate leaders moderating today's discussion. Thank you.
Great. Well, thank you so much for having us. We're very excited to be here.
Yes, thank you very much. So, Diana, do you want to just give us a quick, where do you work? What do you do? Why are you here?
Sure. So my name is Diana Isaacs. I'm an endocrine pharmacist and certified diabetes care and education specialist at Cleveland Clinic.
Hi, I'm Natalie Bellini. I'm an assistant professor of medicine at Case Western Reserve University, and I'm one of the endocrine nurse practitioners here at University Hospitals, also in Cleveland, Ohio. So let's get started. So I'd love to introduce our panelists, but in the spirit of time, we aren't going to give them the accolades they deserve. But the diaTribe team will post the link where their bios can be fully read, because we could spend an entire hour just on their bios. You guys, our team this session is amazing, and they've got great clinical experience behind them. So first, Dr. Anastasia Albanese O'Neill. She is the Vice President of Medical Affairs at Breakthrough T1D, formerly JDRF. We have Dr. Jennifer Goldman of the Massachusetts College of Pharmacy and Health Sciences. We have Dr. Kashif Latif from the AM Diabetes and Endocrinology Center in Memphis, Tennessee. And we have Dr. Taylor Stevens, a pediatric psychologist at the Cleveland Clinic. Welcome to you all. So, there was a little echo there. Part 1 and 2 of this series, we talked about screening and monitoring. diaTribe will put the links in the chat for those who want to watch and rewatch those. Today, we're going to jump into treatment as well as ongoing trials to delay and prevent stage 3 type 1 diabetes. Stage 3 type 1 diabetes is what I tell people is the diabetes that type 1 that we know and love. You need insulin, a continuous glucose sensor, your glucose is fluctuating. That is the type 1 that we, in the past, that's all we ever knew, right? There was only on or off, and this is very different. And that's important to listen to those other 2 podcasts that we did and broadcasts that we did. So today we're going to talk about those trials to prevent that stage 3 from happening. Sorry about that. So that we type in your questions into the chat, and we'll try our best to get them during the Q&A. We will finish those questions and send out a link to all those answers when we're done. So, Dr. Latif, let's start with you. To recap from previous panels, why is it important to screen and thus know your stage specifically as it relates to treatment and trials?
Well, thank you for that, Natalie. Good to be part of this landmark group of sessions because we are in a different time and in a different millennium, if I may say so. Because a few years ago, discussion like this would be, a thing of the future, and we are here now. So, just to recap, as the previous two sessions have discussed, that think of the diabetes journey, the type 1 diabetes, as a continuum, and you have this predisposition to this autoimmune destruction of the insulin producing apparatus. Then something triggers that, and the destruction starts. And that's what we allude to as stage 1. And then, when adequate amount of insulin producing cells are damaged, we have dysglycemia, which is stage 2, and then we enter the stage of hyperglycemia when a critical mass of islets are destroyed and we cannot maintain a state of glucose control. And that, as Natalie said, is the diabetes as we know it. And most of the patients present in that stage in DKA and with a lot of comorbid states at that time. So it is really important for us to screen to be able to detect the condition in early stages because now we can make a difference. And just to give you an anecdote, if we were talking about this to a patient or a family, especially with our TrialNet folks a number of years ago, a lot of patients and parents especially would be skeptical. We do not really want to know. We don't want to deal with this. Well, the discussion has now switched to the point that, well, there is something that we can do. We can actually make a difference in two folds. Number one is that we can actually soften the landing into stage 3. And number two is that we can now delay the onset of stage 3. Now, the only way we can impart those therapies or utilize those therapies to know which stage we are at. And we now, at this point in time, do have trials which not only deals with stage 2 and 3, but also in stage 1. So it is really important to know where we are on this journey. And we have trials that we can look at and see if that is something that would work for us, and to see if we can be participant in those. And so if we know the stage that we are in, and if we are looking at all of the options out there, then we can say this is where we can be plugged in, and this is where we are a candidate for, and this is not where we are a candidate for. And since it is a continuum over time, then we can say, well, we need to continue to monitor until we get to maybe stage 2, where we will opt for therapy. Now,
That
that is one side of things. The other side is that we now have a treatment that is FDA approved. So if you look at stage 1 and stage 3, at this point in time, we have ongoing studies, but we do not have an FDA approved protocol or medication which is disease modifying. But in stage 2, we do have the Tzield or teplizumab approved, which can delay the onset of stage 3. So
That's a let me just so I'm going to turn this over to Dr. Goldman because I want to ask you about that, right? Can you talk a little bit as a pharmacist about the teplizumab, or Tzield is the brand name? Can you go over the science behind that treatment and how it works to help preserve and preserve that beta cell function, slow down that beta cell decline?
Sure. So Tzield, which is the brand name for teplizumab, it's currently the only FDA-approved medication that can delay the onset of stage 3 type 1 diabetes. So what it is a monoclonal antibody, and it targets a specific immune cell receptor called CD3 on the T lymphocytes. That's part of the immune system. So in type 1 diabetes, the immune system mistakenly attacks the insulin-producing beta cells in the pancreas. Teplizumab or Tzield works by modulating or retraining the immune response so that these T cells become less aggressive. So essentially, it helps reset the immune regulation, reducing the autoimmune attack on beta cells. So by doing this, it helps preserve beta cell function for a longer period of time. And when beta cells continue to make some insulin, blood glucose levels will remain more stable, and the progression from stage 2, which is the pre-symptomatic abnormal blood glucose multiple autoantibodies at stage 2, it it to that stage 3, which is the clinical type 1 that you just mentioned, and that can be delayed. So in clinical trials, on average, that was delayed about 2 years, though in some people the delay was even longer. In terms of the indication and eligibility, at this time, Tzield is approved by the FDA for use in people 8 years old or older who have stage 2. And these patients are typically identified through screening programs such as TrialNet or other family based or community screening initiatives or a provider's office. And once stage 2 is confirmed, individuals may be evaluated for treatment eligibility. In terms of monitoring administration, Tzield's given in a 14-day intravenous infusion once daily in a clinic setting where patients are monitored for infusion-related reactions such as mild rash or flu-like symptoms. Before and during treatment, blood counts, liver function are monitored as well. So the key takeaway, Natalie, and everyone out there, is really that Tzield doesn't cure or stop type 1 diabetes, but it buys valuable time. It delays the need for insulin and giving individuals and families more time to prepare for life with diabetes while research continues toward true prevention.
I love that idea. But so, Dr. Albanese O'Neill, can you talk a little bit about like how long can it delay, and can you talk a little bit about that whole period? Because I think this is one of those challenging things when you have someone that is antibody positive. The first thing is you don't know how long they've been positive, right? And so when we infuse Tzield in someone with stage 2 type 1 diabetes, we can't guarantee how long that process has happened. So can you talk a little bit about that, how what the beginning to the end, and what someone could expect?
Absolutely. Thank you for that question. Because, as we move toward precision medicine, there are variable rates in response to therapies. So if people are on this call, it's a random Tuesday afternoon and they're listening to a lot of science here. I want to point to the evidence. So the first journal article I want to point you to is one by Kevin Harold, published in 2019 in the New England Journal of Medicine. I think we're all familiar with that journal. And this was the results of the pivotal trial. And what we learned is that people who got the drug, they went about 48 plus months, 48 and change months, without progressing to stage 3 type 1 diabetes. For people who got the placebo, they went 24.4 months. So it's exactly 2 years longer, the median sort of time to requiring insulin in stage 3 type 1 diabetes. So 2 years means different things to different people, but that's a really, really important first data point. These data were reanalyzed later by Emily Sims, and we can drop these in the chat in 2021. And what she saw was a bit longer for the group that received the therapy, about 2.7 years. But not everyone is a responder. It's about a 50 to 60% response rate. And so I think when you're thinking about this therapy, I think you need to know that not everyone responds, and that's why we need more research in this space. Some people respond a much shorter period of time. Remember, we're talking about averages and medians, some a much longer period of time. But I would also add, and I can share some citations here, that there's evidence that if you can retain just some residual beta cell mass, those cells in the pancreas that can produce insulin, which we can measure with a lab called C-peptide, this has some additional benefits. I think people listening are familiar with DCCT, the study that gave us sort of, advanced sort of treatments that we all are following today. What we know is that residual beta cell mass, so the ability to produce even a little bit of your own insulin, has been associated with fewer severe hypoglycemic events. Smaller studies have suggested that retaining this beta cell mass is associated with lower A1C, more time in range, a reduction in long-term risk of complications related to the kidneys and eyes. So I think that these are all really important things to keep in mind as added benefits. And I would be remiss if I didn't add that here at Breakthrough T1D, we hear a lot about people sharing that they get the gift of time. That 2 to 3 years really matters for people who are responders, because they do not need to take insulin and all the work and potential complications associated with that in stage 3 type 1 diabetes.
Yeah, I think that you really did hit the nail on the head there. It's about buying time, but it's also about this residual beta cell function, as we are going to talk later in this podcast about the idea that there are other things coming. So for people who have zero beta cell function left versus some, and it's strange because some people have it for longer than others, right? It's not an on off for a lot of people with type 1 diabetes. Those people will have other options than people who don't have any beta cell function left. So we are buying time for the next thing, which we didn't know even existed before now. And so when we talk about further research, we will definitely get to that today. So Dr. Stevens, though, as a psychologist from the mental health perspective, by delaying type 1, what does this extra time mean for emotional well-being and preparation?
Well, you perfectly teed me up with that previous answer. And, I think the idea of the gift of time enables a multitude of things, and it's not going to look the same for every patient or family. I think building off of the biological benefits, maybe that initial blood glucose stability, less dramatic highs and lows, maybe more smooth impact on glucose fluctuations, that can ease patient and family into the adjustment to the diagnosis. We know that there's a bidirectional relationship between mood and glucose levels, especially in our kiddos. And so the blood glucose stability can actually also contribute to mood stability or maybe less difficulty in that emotional adjustment. Additionally, it allows for more time for that emotional processing, which can be structured and supported by behavioral health or social work or just their own peer network. This is true not only for the patient, but their loved ones or caregivers. Research suggests that parents and caregivers often put their own adjustment to diagnosis on the back burner until they've gotten through several months of a diagnosis. So this time may afford them to process that at the forefront and enable holistic well-being for a family. Additionally, education. I think this is a big one. At initial onset, they are bombarded with all of the education that they are receiving, which is all crucial. We can't really cut any of that away. So enabling a longer span spread out of that education enables potentially easier grasping of the content, building and scaffolding of how we're introducing that content. Additionally, I think we can customize and tailor the treatment approach to each patient and family. For a family that maybe struggles a little bit more with the carb counting, okay, we can spend more dedicated time on that. Or if a child is struggling with needle phobia, how can we build a coping plan and work on strategies to reduce that across time? So when we get to a place where that is necessary part of treatment, maybe we've reduced that emotional impact. And lastly, I think combining education and the psychological piece, it creates space for other options of processing. How are we going to be sharing this information with others? With kids, it is often how are we telling our classmates? How are we telling our friends? And we can build plans ahead of time so they don't feel like they have to immediately do it upon diagnosis. It can also enable developing coping plans in other areas, for sports, for activities. So it creates a lot of opportunity to customize treatment approaches to address each individual and family needs.
I love that. I love the idea of a soft landing because it feels like, even with adults with type 1, it feels like you're putting a fire hose in their mouth when you say, okay, this is a carbohydrate. This is how things done. Then you need to do this. And then you need to think and then stress. And then, and it's just like, oh, and then of course you take too much and you're going to have a severe low and you need to have this other hormone called glucagon. I mean, it's a lot. It really is a struggle. So the idea of a soft landing really can make a difference for children and adults alike. Dr. Goldman, we do understand, though, that TZIELD has also been studied in stage 3 type 1. They've actually, it has been submitted for approval, and a new indication may be coming in the near future. Can you talk to us a little bit about that?
Sure, and that's a great question. So while TZIELD's currently approved only for stage 2 type 1 diabetes, there is so much interest in expanding its use to people who have already been newly diagnosed with stage 3 type 1 diabetes who require insulin. So the main study looking at this is called the PROTECT trial. It enrolled children and adolescents age 8 to 17 who were diagnosed with stage 3 type 1 diabetes within the previous 6 weeks. So the idea was to see whether using Tzield, teplizumab, soon after diagnosis could preserve remaining beta cell function, since at diagnosis, many people still have some insulin-producing cells left. So in the PROTECT study, participants received a 12-day course of Tzield within 6 weeks of the diagnosis, and researchers measured how well the pancreas continued to make insulin over time. So they received a second 12-day course at 26 weeks, although some were actually 52 weeks because this all happened during COVID, so there were some delays. But the results showed that children who received Tzield had better preservation of their own insulin production, and as measured as C-peptide, which we just heard about. So compared to those who got the placebo. So this means that their bodies could still make some insulin longer, which often translates into less variability in blood glucose, lower insulin needs, fewer hypoglycemic episodes. So the data from the PROTECT trial is very promising, and the FDA, as you said, is currently reviewing this evidence for potential label expansion. And if approved, it could give newly diagnosed patients and families another important option to help preserve beta cell function and potentially make diabetes easier to manage early on. It's actually under expedited review, so we may hear about it in the next 1 or 2 months. So Tzield may soon play a role not only in delaying type 1 diabetes, but also in changing the early disease course once it's diagnosed.
Wow, that's incredible, because Diana, I can see you smiling already. It's like this idea. I know who has stage 3 type 1. They're in my hospital right now, right? They're in my peds hospital. They're in my adult hospital. They are easy to find because they're in DKA, and we can maybe, if they have residual beta cell function, protect that, even though they have to start on insulin.
Right. I just see it opening the floodgates because stage 2 is a little bit more challenging to catch. It requires screening, and we're encouraging more screening, but not everyone's doing it. But stage 3, you're absolutely right. Like, unfortunately, they do often end up in the hospital. And so we can potentially be able to offer this treatment if it gets approved, and hopefully it will. So I want to go ahead and shift a little bit to something I think many families are probably wondering about, and that's like, what are the how-tos with Tzield? How does it really fit into daily life? And so, Dr. Goldman, I'm going to turn it over to you first. What does this treatment actually look like? I heard you mention that it is IV, but like, how many days? Like, how long do you have to sit there? Do you have to take off from school or from work? So I'm curious, how do you answer all of that?
So that's a really important question, because families often want to know what the treatment actually looks like on a day-to-day. So Tzield's an intravenous infusion. So there's one dose daily for 14 days in a row. Each infusion takes 30 to 60 minutes, and it's typically done in a specialized infusion center or an outpatient clinic where nurses and providers are experienced in monitoring for any mild reactions such as rash, fatigue, flu-like symptoms. Most people tolerate it quite well, and they can usually go about normal activities afterward. The location may vary depending on the provider or the area in the country. Some people might go in for the first 5 days and get the rest of the infusions at home. It really depends on that provider and the availability. Before starting treatment, the healthcare team will order some baseline blood tests, and that includes complete blood counts and liver function tests, and that's just to make sure it's safe to begin therapy. And those labs are repeated during and after treatment to monitor for any side effects. And because this is a 14-day commitment, it is helpful to plan ahead. So you need to think about school and work and travel, because you want to complete this infusion consecutively without interruption. So, what questions might you ask the healthcare team before you start? I would encourage families and patients to ask a couple questions like, where will the infusions take place? What support is available? What do I do if I have a reaction? How will you monitor labs when you follow up with treatment? So the process may sound intense at first, but it's just 2 weeks of infusions. And for many families, that 2 week investment can translate into months or even years of delayed diabetes progression, which is a major milestone in this disease.
Thanks. Yeah, thanks for describing that. And I think that is absolutely right. 14 days, but it's a one and done. And so it's exactly like you said, a 14-day investment. I know at Cleveland Clinic, we typically do this as outpatient, and then we also offer after the first 5 days to do home infusion. So I think there's different options of how to receive it. So Dr. Albanese O'Neill, I'm curious from, if you can share, well, what are some of the potential side effects that could occur with this, and how then might that potentially impact school or work or other activities during this time?
No, that's a great question. I want to build on what Dr. Goldman shared with us. What we know are the most common side effect is what we would call lymphopenia, and we also see leukopenia, which is the medical way of saying lower white blood cell counts. And I just want to reassure you that this is expected based on the drug class. This is an immunomodulatory therapy, so we would expect that, but we would also expect those to return to baseline. So in terms of school or work or other activities, I think it's really important to ask the questions that Dr. Goldman mentioned. Get advice from your care team on a personalized plan related to your work and social activities during the infusion, and I would say in the month following, as you're waiting to get those follow-up labs. And again, because this is an immunotherapy and changes the way your immune system functions, albeit temporarily, your care team will also provide advice on pre-infusion vaccines that are recommended, and also check for active infections at the time of your infusion. So it's really important that you do all of the pre-infusion follow-up. This is, take these 14 days seriously. As she said, it's one group of 14 days. It's a one and done, but we want to make sure that you set aside the right amount of time to get those things done. I want to address some of the other common side effects she mentioned, like rash, nausea, headache. I was really lucky to hear an update from Kimber Simmons at the Barbara Davis Center just last week, because the drug was just approved in Canada. So she was talking to health care professionals across Canada. And, as we get more experience, or as clinicians do with this therapy, many sites are pre-medicating before the infusion or giving additional fluids to sort of address rash, nausea, headache, and some of these other minor symptoms. And then I would be remiss if I didn't share that a fairly rare side effect, but it can happen, is called cytokine release syndrome. This is why this is done in the hospital setting, which is characterized by fever, possibly hypotension or low blood pressure. Often this is managed with IV fluids, but a person may require additional interventions. But this is why it's important to get the therapy in a clinic with experience infusing the drug that has protocols in place. And having said all of that, I want to be very clear. This drug has been, Jeff Bluestone and Kevin Harold started working on this therapy in the 1980s, before many of you listening were born. It's been around for a long time, and the first clinical trial in stage 3 type 1 diabetes was in 2005. We've got a lot of safety data on this drug, and what that means is clinical teams understand its safety profile. We also know that safety profile is very predictable, and when this drug is infused, they can predict what might happen, they can monitor for it, and they know how to take care of you and address these symptoms.
Awesome. Thanks. I mean, that's a great overview. And Dr. Latif, I know you have had several patients undergo the Tzield infusion. I'm curious what you've noticed in terms of, should their caregivers plan to take time off work or school during the treatment? How do most families manage this?
Yeah, absolutely. A couple of points, as Anastasia and Jennifer talked about, is it is a biologic. So we need to be prudent, because we are going to have some change in your immune profile, at least initially. And so you want to take precaution. And most of the studies were done in younger age people. And as they will get medicine and want to be with friends and want to be outdoors. So you want to plan for that. You want to make sure that you kind of put some kind of boundaries there to make sure that they are not under any kind of danger. Number two is that the families, it's not one person getting it, it's the whole family decision. And if it is a young one, then it's the parents, and it could be mother or father. And during the studies, patients were really eager to participate, and we're already thinking about things. Now we are at also a different point where we have patients who get diagnosed in stage 2, and they come in under the same category. But how about somebody who's in stage 1? And when you have a conversation with them, you start preparing them. If you're not going to be part of a stage 1 study, then if you're in stage 2, this is what to look forward to, this is what you should think about. So just to plant the seed in their head. Now, there are two different kinds of cohorts, if you will. One is somebody who already has a family member, first degree or a second degree relative with type 1 diabetes. Their responsiveness, their uptake, and their uh, eagerness to participate is going to be slightly different than somebody who you just diagnose with two autoantibodies, and you say, hey, you have type 1 diabetes, and these are the options at early stages, and this is how you're going to talk about. So the conversations are slightly different. We have to be really in tune with that side of things. And number two is that, yes, it is a long therapy, but the benefits are way worth it. And a lot of people who have the condition or have a family member, they say even one day is worth a lot of treatment that we can go without the need for insulin.
I love that. Yeah, about being proactive. And I love the last thing, that even one extra day without diabetes makes it worth it. So Dr. Stevens, I'm curious if you have any suggestions for the emotional impact side of things while doing this infusion treatment. Anything you need to prepare for, anything we need to be communicating to schools for children?
Yeah, I think actually all my colleagues just set me up beautifully again. My overarching theme is proactive planning. So I think, again, this looks different for every patient and family. But since it is going to be a scheduled infusion series of appointments, I think we can be intentional with when the planning is. Obviously, when dealing with pediatrics, it would probably be prudent, if it's within the appropriate window, to try and avoid big important dates. We might not want to be sitting in an infusion chair on our birthday, or do it during our prime sports season, if at all possible. Obviously, the eligibility window is specifically built for a reason, but trying to be intentional with the planning of when we do the infusion is best. This can also allow parents or caregivers to appropriately plan for FMLA or PTO in order to be there present with their child. I think additionally, while many aspects of this are out of a family's control, being able to schedule this can also create a sense of control, which in the world of diabetes, there is very little sense of control. And I actually encourage all my patients to remove that term from their vocabulary. But being able to schedule it does create a nice planning opportunity. Additionally, planning with the team. So who can we enlist to be supports for that is key. What are things that you know about your child or yourself going into something like this? As mentioned, it is an IV infusion. So how are we going to handle those pieces? You can be proactively connected with behavioral health, psychology, or social work, and they can help with some of those communication pieces. So while obviously there isn't a stage 3 or full type 1 diagnosis yet, but you could work with a behavioral health or psychology provider to put in place a letter related to a 504 plan or a fully structured 504 plan, which is through schools to have accommodations for a medical reason. So that could enable, how are we going to address missed class time? Are we going to be getting a packet of work sent home? While it is a shorter infusion compared to some other more standard infusions where you may have heard for like cancer, where they're longer, it is a shorter infusion, but some kids may not feel comfortable going back to school after, and that's okay too. So figuring out ahead of time, how are we going to approach this? So that way we can really enable a tailored approach to best meet the patient's need and any caregivers involved. Lastly, I was going to say, pack anything. It's shorter, but with kids especially, we need to have fun distraction things. Obviously, my background is full of them, so that might be coloring supplies, books, an iPad with preloaded videos or music to listen to. So packing things to help pass the time and reduce any associated stress.
Yeah, I love your office. Like, I want to go hang out right there. So that's got to be a lot of fun for kids.
It's full.
And then just switching gears just a little bit, Dr. Latif, I'm curious what you've been noticing just about access and coverage of TZIEL, because I'm sure a lot of people have questions about that.
Yeah, if I go back a couple of years when we were infusing our first stage 2 patients, we had to go through uh, the process with the insurance companies, and it took a long time. And they would first say a letter, "This drug is covered," but that was just a blanket statement. It didn't mean much. And then they came back and say, "Well, it's covered for 8 days." So the process was really long, but the last patient we did just a few weeks ago, it went very smooth. So I think most of the kinks have been worked out. Number two is that now insurers are also aware of the therapy and the potential benefit, and if they did not see the benefit in that delay in stage 3, they would put up a lot more hurdles. So in the experience that I have had in trying to get drug for the patients that we have gotten the medication to commercially, it has all been very positive. And I think that we do have some other programs that anesthesia may talk about support with where coverage is not optimal.
That's great to hear. And I know the criteria is so specific that I know it's been my experience when people fit that, usually you get it covered. So it's great to hear.
Can I just add one thing? There's a TZL Compass program. That's a patient support program, and that helps eligible patients get access and education and resources. And I know with commercial, it's people pay $20 or less.
Yeah, that's great.
So we just discussed the therapy option that's available right now to delay that onset from stage 2 type 1, which is, by the way, a true diagnosis of type 1, right? Stage 1 type 1 is type 1. Stage 2 type 1 is type 1. And that delay from stage 2 to stage 3 and how we do that and what that looks like. So one conversation I had with Dr. Anastasia, I don't know, a handful of years ago now, I was like, this is so great, and da-da-da-da-da, and we're getting there. And she's like, Natalie, I don't have enough people to fill trials right now. And I said to her, what? And she said, I need more people. And so I'd like to talk a little bit about that. Can you talk about what it's like to be in a clinical trial? And what kind of trials are there? So let's start there.
Yes. So I will happily talk about clinical trials, and I'll just remind everybody that the only reason we have this therapy available in stage 2 type 1 diabetes is because people participated in clinical trials. So while we are celebrating this opportunity to delay the progression from stage 2 to stage 3, just keep in mind with an approved therapy, which I am still very delighted about. Just remember that we wouldn't be doing that if people hadn't participated in clinical trials. So let me take what you asked one question at a time. Participating in research is essential for us to get therapies across the finish line. And I would say, as a person who's participated in clinical trials and also led them, I consider it an upgrade to first class because you get to interact with the physicians and nurses and other healthcare professionals who are at the cutting edge of their field. You often have a lot of time with them when they're doing an OGTT or other procedures, and you can ask all kinds of questions about new devices and things completely unrelated to the trial. And I think people need to remember in clinical trials, you're in control. Research is voluntary, and you're in the driver's seat. But I think if you're listening and you haven't participated in clinical trials yet, please consider it. Natalie, you asked what are the types of clinical trials? Well, there are all kinds of clinical trials in type 1 diabetes. They are for people across the lifespan from age 1 to age in your 8th decade of life, and they cover the care continuum. So this could be a trial on diabetes distress. We've got Dr. Stevens here, but you also might have a study on tech or other therapies to delay and ultimately one day prevent type 1 diabetes. And now we have in-human cell replacement therapies. I think you asked where they take place. Most of the therapies and clinical trials around therapies to delay and prevent type 1 diabetes and protect those beta cells take place in the clinical setting or in the hospital. But I want to remind people that if you don't live near the place where the study is taking place, and this was true in the teplizumab pivotal trial and all the ones that took place before it, there is funding to fly you there and a care partner and to cover some of those costs. So don't think just because you live in a rural town or somewhere the clinical trial isn't happening that you can't participate. You can. So I've got a call to action. I always have one when I join these events, and I'm going to urge you to look on our website and look at the list of clinical trials that are there, or use our finder and think about leaning in and helping us get additional therapies across the finish line.
I love that. I actually use the Breakthrough T1D website, the Find a Trial website, with all new patients who walk into my practice. I pull it up and I say, how long have you had type 1? Where are you? What are you interested in? Show them how to look. And I think it's really important for clinicians to help people with diabetes have access to trials or even discuss them. I mean, there are trials that just want to look at your CGM data, for example. They don't even want, they don't touch you. They're not taking people think that they're going to be in a bed and they're going to have gallons of blood taken, and none of that, right? It doesn't have to happen, right? So I think that we have to remember that there's all kinds of trials. Some of them are very intensive, but some of them are literally, can we see your numbers? Can we see your pump data? Can you give us blood every 6 months? It can be very, very simple at the same time.
Natalie, can I just jump in here and say, again, that call to action, we have compiled a list of what we call virtual clinical trials. These are to your point, these are clinical trials that you can participate in from your couch or just by going to your local lab. So I want to encourage everybody listening. I'll drop it in the chat, but find our virtual clinical trial flyer and consider getting involved, because we need in type 1 diabetes to create a culture of clinical trial participation, and not just in our community, but I think I love how you mentioned among healthcare professionals. We've also got some healthcare education on our website where you can learn about the currently recruiting clinical trials, so you can feel comfortable talking with them when you're in clinic, talking to people affected by type 1 diabetes. So everybody, think about a virtual trial. I challenge you. Check it out.
I think I want to add on that. I want to tip my hat to all of the people who have participated, because these are long, difficult studies, and if they had not participated, and we would not have the TN10, we would not. And remember, that was like a decade-long trial, and so people persevered because they believed in changing this disease, and we are at the cusp. And I think more people that participate in all these trials, we need all that.
Agreed. That study did, and sorry, one more time, but Kashifa's bringing up a really important point. The pivotal trial for teplizumab took 10 years, but we are seeing studies now take 2 and 3 years. Why? Because the community is activated and starting to lean in on these trials, and healthcare professionals are talking about them. So let's continue that momentum. Let's not have a study take 10 years. Let's have the study take 3 to 5 so we can get to the answers up or down faster and move forward.
Absolutely.
I think that's a great way to think about it, right? We are talking to people. We are getting people to screen their children, even just for type 1. Who are we screening, right? The ADA guidelines now say what? They say first-degree relatives. If you have type 1, it would be your parents, your brothers and sisters, and your children, right? That's just the tip of the iceberg. But we are at least starting someplace. People with thyroid disease, people with celiac disease, all those people that have a higher risk should be screening, right? But are there other trials right now, Dr. Albanese O'Neill, that you're super excited about with type 1 that you want to touch on? Some of the Breakthrough T1D funded trials. I know this is your wheelhouse. You're like starting to shake. She's like, yeah,
you open the door.
Yep.
You open the door,
right? Yes, exactly.
You open the door. I'm going to walk through it, and yep. I would say that this is what is particularly spectacular about living. One of the exciting things about living in the here and now. What I want to note, though, is that clinical trials to delay. So I'm going to focus on the clinical trials that are going to delay type 1 diabetes progression and protect those beta cells. we always started stage 3 with those studies. Again, back in 2005 with the ABATE study, that's where teplizumab was first tested in people in stage 3 type 1 diabetes. And as it met with success, it was moved back to stage 2. And now we have an approved therapy that delays that progression. So we don't have any studies right now in stage 1 or 2. We may soon. If I mention anything, I will be violating some kind of confidentiality agreement. But I can say that we have a lot of studies in stage 3 type 1 diabetes. So if you are listening on this call and you've been recently diagnosed with stage 3 type 1 requiring insulin, or you know people in the community, or you're a healthcare professional and you're talking to people about research opportunities, I really want to encourage you to think about one of these studies. We have another flyer that's called Disease Modifying Therapy Studies. And I can tell you that right now there are 8 studies recruiting for people at a stage 3 type 1 diabetes diagnosis. 8 studies. Years ago, when our daughter was diagnosed, there were none in her age group. What I want to underline, important to note, is many of them require you to enroll in the first 3 to 6 months following that diagnosis. And I want to acknowledge this is a really difficult time. You're overwhelmed and you're busy and you're trying to readjust your life to taking insulin and changing things at school and at home. But this is the essential time when you need to make a choice about participating in these studies. And we've got all kinds of therapies being tested: DFMO, antigen therapies. We have a study with a drug called frexalimab, which has had some really nice results in multiple sclerosis. So community, this is a diaTribe event, type 1 diabetes community event. Let's share the word and work together to create that culture of research participation that we're talking about. And there's one study I want to highlight because you don't have to do it right after you are diagnosed. It's in 1 to 5 years post-diagnosis, testing an osteoporosis drug where we've got a lot of safety data. So if you're out there listening and you've had type 1 to 5 years, there's a study for you that can help us learn more as well. So have a look and get involved. I'm going to drop it in the chat. I'm going to head over and drop that in the chat so people can have a look.
And again, if I may iterate, we talked about this, that even if we preserve a fraction of the insulin producing capacity, the complications are far less, the hypoglycemia, hyperglycemia, it is way worth it, even if you have stage 3. Absolutely. Please, I encourage you all to participate.
I love that. I love that comment because I think you're right. I think even a tiny bit of beta cell function is better than none. And that's what I think we need to remember as we move forward through this is early stage 3 type 1. If we can capture those little bit of beta cells that are left and keep them functioning for as long as possible, that really is going to change outcomes. That's what I believe in my heart. I truly do. So Dr. Stevens, with all of this, whether it's going through a clinical trial or a treatment, what are some of the main emotional or mental health supports available to families?
Yeah, so this will differ depending on the institution that you're going to, but largely some things to ask or inquire about are supportive services. So there are things like art and music therapy that can be done during the infusion appointments or at other times during any admission or anything like that, which can help pass the time and process emotional reactions. There is a wonderful service called Child Life, and even though it has the term child in it, there should also be an adult side facing of Child Life. And they're incredibly helpful for procedural support. They can explain things in developmentally appropriate ways, especially how do we explain to a young child, okay, we're going to go get this medicine for 14 days, but right now you don't necessarily have a traditional diagnosis, we'll say, of type 1, even though it is type 1. How are we explaining this to them? How are we getting their buy-in? So Child Life is incredibly helpful. They can also be there for procedural aspects like pokes, the IV placement. They have tools like Buzzy Bee or Shot Blocker that can help physiologically distract. And then obviously behavioral health or social work support as well. There's lots of developmentally normative ways to talk about these things. There are a slew of diabetes books for kids. You can have coloring sheets. There are ways to process this in a kid's language, which are often play and stories. So I would inquire asking what your institution or agency has to offer and try to plan those in advance.
I love that. I do. Okay, so Dr. Albanese O'Neill, one more thing. Do you think one day we'll be able to fully prevent or cure? Where do you fall on that? Oh, you're muted.
I committed the muted the muted faux pas. Dr. Bellini, I would not work in this space if I didn't believe that one day we will find a way to delay and ultimately prevent type 1 diabetes. Can I predict the timeline? No. But what I can say with absolute certainty is if we do nothing today, we will be in the same place tomorrow. And if people hadn't, again, if people hadn't been those research heroes, if they hadn't participated in insulin pump studies in the 1970s and 80s and 90s, we would not have automated insulin delivery systems today. But if we continue funding research, and as a community, if we create a culture of research participation, we will be closer tomorrow than we are today. So there's a lot to be hopeful about. I think about cell replacement therapy, clinical trials that are in humans. I think about improved automated insulin delivery, continuous ketone monitors. And I love the dialogue that we've had today. And specific to teplizumab, I want to remind everybody listening that the Nobel Prize was just awarded to Mary Brunko, Fred Ramsdell, and Shimon Sakaguchi. Why? Because they did work on immune tolerance. All of the science undergirding this approval of teplizumab and these future clinical trials, the Nobel Committee recognized the significant progress we're making, and specifically these contributions by these three scientists in teaching the immune system to stop harming the body and to stop attacking self, in this case, the insulin-producing cells in the pancreas. So we have gotten teplizumab over the finish line through the clinical trial process, through the regulatory process, and into the lives of people with type 1 diabetes in stage 2, but it won't be the last. We have a lot of work to do, but I am hopeful, again, that as healthcare professionals, researchers, funders, industry partners, and most importantly, people with type 1 diabetes and their families, we are going to work together and be partners to get this across the finish line and to get the job done. And maybe I'm overly optimistic, but I believe we will get there.
I love that. So in closing, to each of our panelists, can you each answer one main closing thought of hopeful and actionable information around this discussion today?
And I'm just going to chime in short, really short.
Yep,
So
because we got to get to some questions.
Q&A.
Yep.
Yes, concise. Should we start with Dr. Goldman?
Sure. Sure. Every step we take toward identifying and treating type 1 diabetes earlier brings us closer to true prevention. And I think that that's something we can all be encouraged by.
Awesome. Dr. Stevens.
I would say flexibility within fidelity. So we'll build a plan together to best support you, but also being flexible and meeting your child or family's needs if you are going to proceed with participating in a clinical trial or treatment.
I love it.
I love that.
Dr. Latif.
Start the dialogue. Start the dialogue to push screening and for evaluation, not only first degree, but universally.
And Dr. Albanese O'Neill.
Consider participating in screening. There is a research pathway for family members. There is another research pathway for everyone, 1 to 99 in the United States that we're funding, that people in the general population can participate here in the US. And again, help us create that culture of research participation, learn more about clinical trials, and get involved.
Thanks. And my takeaway as a healthcare professional, I need to offer these clinical trials and make sure my patients know where to go. So thank you for that.
Pleasure.
Well, thank you, everyone, so much. Thank you for our sponsors for having us. And thank you for our participants and our panel today. Let's get to a couple of questions. Diana, do you want to do the first
Yeah,
one?
I can ask the questions, and anyone who has more, please put them in the chat, and we'll try to get to as many as possible. So our first one is, why does this medicine only work for 2 years? So I don't know, Dr. Goldman, you want to answer that?
I wish I had a really good answer for that, but everyone is different, and there's actually research that has been done that to help try to predict who's going to be a responder and who's not going to be a responder. I don't think it's quite standard yet, but that's in the works. And I think that, having clinical trials and more research can certainly answer that. But
And I think that's a really good response, because it's like, when we look at the data, right, that average person was out 56 months plus or minus, right? But the thing we need to remember is there are people also out 10 years from
10
that,
years,
right?
exactly.
So
Exactly.
how is
Wasn't
someone, we
everyone.
need to look, this is where precision medicine, and this is my love. It's like, who gets the drug and doesn't really get a whole lot of delay at all? Who are the people who get the drug and get 10 years, right?
Yeah.
I want to be that person. It's too late for me. I've had diabetes way too long. But how do we predict who's going to get that? Because then we develop the next drug called, teplizumab B, right? Like, and so we make it a little bit different and we make it last longer. And the person does this, or we add this to it. That's kind of where I fall in this whole approach.
And I think if I
Yeah.
may add, there's a continuum. So you may have just entered stage two, or you may be towards the tail end of stage
Yes.
two. You're just getting enrolled in the study. And so that's why studies in stage one and stage three are also important, so we can understand this paradigm and spectrum a whole lot better.
And just to add, just a sentence or two. Remember, other autoimmune conditions. Think about combination therapies, where we extend the median of 2 years or 2.7 years further by using that therapy in combination with another, and that's where the field is going, and that's why these clinical trials are so important. We need to learn from other disciplines about how we can use combination therapies and precision medicine to meet each person and get them the therapy they need. So exciting stuff.
Imagine if we can buy time, whether it's 2 years, 5 years, or 10 years, what can we discover in that time that might buy more time?
I love it. So another question, and I'm going to direct this one to Dr. Stevens to start, is someone really likes the expression of soft landing. How is it best to explain to children, maybe like around 7 or 8 years old, that they have diabetes, they have these autoantibodies, but like they don't need insulin?
Yeah, it's a great question. And honestly, my answer may be a little frustrating because I think it's tailored to each kid. Every kid understands things differently. There are lots of ways that we can use developmentally appropriate language. We can talk about insulin being the key that unlocks the door. There's lots of different analogies we can use. There are also handy books where we can explore what our body does and why it does certain things, and explain in more plain language why we might be doing something. But developmentally, they aren't able to see, well, I'm at point A and we're trying to prevent the onset of point Z. So it's really going to be using language that makes sense to them. And then I think answering any of their questions honestly, I think that's one of the most important things, is being transparent and honest with them to the degree that we can. It's important to foster their sense of being able to ask questions and get answers and be comfortable with the unknown, because we don't know all the pieces, but this is part of the exciting aspect of it. So I think it's custom to each kid, but using partners like Child Life or behavioral health can also aid in those discussions.
Dr. Albanese O'Neill, do you have can you direct people?
Yes, I can. So I want to ask people for help, and I also want to direct them. So in asking for help, this is really a new population of people, isn't it? People living in early stage type 1 diabetes. So we have asked two psychologists like Dr. Stevens to work with us on doing some focus groups for people living in early stage type 1 diabetes. We are recruiting for those very soon. So if you are a person or the parent of a child living in early stage type 1 diabetes, we want to hear about your lived experience. And we want to hear what support you need and education you need, and we want to hear it from you. So that's my request. The second is where to direct people. We worked with 4 other amazing psychologists. Again, I love Dr. Stevens, one of the most important people on this call. We worked with 4 psychologists to do an hour-long educational offering for healthcare professionals, but you can listen in if you're not an HCP, about how do I manage this kind of different stage of type 1 diabetes. It's an hour long. It's excellent. It's free on our website, and I'll drop something in the chat where you can listen either as a person in the community or a healthcare provider, and you can get some free credits. So I'm going to drop that in for everybody.
I'm sure it's going on, but we have to be mindful that a child just has antibodies, normal sugar. What about the siblings? How do they take it? Does the child get a differential kind of treatment from the parents? So I think that those are very important issues in the family's life and makeup that hopefully the studies will help us deal with.
And another question comes from Sim B. The trials you're referring to are only for US citizens, correct? So I think this is really interesting because, right, because the answer in short is no. Sometimes I see that Breakthrough Type 1 is doing research in Europe or in the UK, and I'm like, oh, I want that. I want that right now. So it does vary country to country, but there are absolutely trials in other countries happening. There are trials in Canada, there are trials in the UK, Europe, Asia. You really, it's hard to go to a country where there aren't some trials for people with type 1 diabetes.
Yeah. And Natalie, you mentioned our clinical trial match tool, so I'm going to give people a tip. But if you type in your city, wherever you live, I don't know who asked that question, if you're in Berlin or Kuala Lumpur, but if you type in your city to our match tool, it should match you within a radius that you specify. And I will, like I like to do, I will drop that into the chat as well.
There's also a question in here on how to find like centers that offer the infusions. I assume the Tzield infusions.
If I could mention, I forgot to mention this when I answered earlier, but if you have not yet heard of Ask the Experts, which is based at the Barbara Davis Center at the University of Colorado in Denver, this is funded by our partners at the Helmsley Charitable Trust. And you can call as a healthcare professional to get upskilled on all of the things we've just talked about, or as a person living in early stage type 1 diabetes or with a child, and they will give you virtually or in person personalized advice and listen to your questions and speak with you. So ask the experts. I got to drop that in the chat too. I'm going to need some help following up, Diane, but that's another great free resource that can help you across. Again, this is US based, but let me leave that in the chat for everybody. It's free. Please use it. And again, personalized advice.
Yes, and thanks to our friends at Helmsley for that, because they do fund a lot of type 1 research in the United States, you guys. They are some of the biggest funders outside of Breakthrough T1D and research in all kinds of treatments for people with type 1. So real quick, I have LADA. Does that mean I've always had the antibodies, but they did not activate till I was 50? I love this question.
So we just put out a request for applications in adult type 1 diabetes early stage and screening. We need to know more about adults. I would say that the preponderance of our data comes from studies in pediatrics, and we need to know more. We think most people seroconvert or develop autoantibodies in childhood, but we don't have enough data on adults to confirm that. So we would encourage you, again, that ASK study that I mentioned, they will screen anybody ages 1 to 99 in the US. No history of diabetes, or if you're a family member, participate in TrialNet. They screen up to age 45. The more people who participate, the more we can learn, and the more we can do a better job of answering that question. Likelihood that you probably had autoantibodies for a number of years, and at some point, as your beta cell mass was destroyed, sort of tipped over into stage 3 type 1 diabetes, where you could not keep your glucose levels in the target range. But that's what we know today. More to come.
Awesome. And with that, I can't believe it's been an hour already. This has been an incredible discussion. I want to thank the panel so much. I want to thank all of you for attending. And there is some time to network with your peers afterwards. But I really, again, want to thank the sponsors, and we're grateful that everyone is here.
Thank you all.
Thank you. It was great.
Thank you.
Thank you.
Thank you.